Hi, I'm Stephen Lee with Elisa Konofagu at Columbia University, and today I'll be talking about FUS-induced median nerve stimulation altering thermal pain sensation in humans. 7 to 10% of the global population has some sort of neuropathic pain. This has led to increases in clinical visits as well as increases in opioid use and misuse. Alternative treatments such as electric stimulation, magnetic stimulation, spinal cord stimulation have been proposed, yet they have large drawbacks, namely being invasive or non-localized. Moreover, high efficacy over placebo effect has yet to be conclusively shown. Focused ultrasound can affect neural activity at all levels: brain activity, brain circuits, peripheral nerves, ion channels, organs, and it's been shown in various different animal models such as rodents, sheep, monkeys, and humans. Our lab in particular has used focused ultrasound to stimulate the sciatic nerve, resulting in a compound muscle activation. And using different FUS parameters, we can also suppress electrically evoked compound muscle activations. Moreover, we've looked into humans and applying FUS to the median nerve and looking at the EEGs. So the question remains, can we use focused ultrasound to treat neuropathic pain? To test this, we apply thermal stimulation to the C6 dermatome in the palm. This signal is transduced up the median nerve, and then upstream of the stimulation site, we would apply focused ultrasound to the median nerve directly and non-invasively through the skin. We would apply a thermal stimulus for 2 seconds, and this would be a 30 to 50 degrees Celsius pulse. And at the peak of this heat, we would apply FUS or sham pulse for 5 milliseconds. And then afterwards, we would ask the subject for a pain rating based on the Wong-Baker Faces pain rating scale from 0 to 10. And then we would wait 2 to 3 minutes and repeat this 15 times. The FUS parameters we're using here is a 1.1 megahertz 4-element transducer. We're applying sonication for 5 milliseconds and a single pulse per thermal stimulation. And the pressure we're looking at is 0 to 7 megapascals, where each subject only receives one level of pressure the whole experiment. And again, the interstimulus interval is 2 to 3 minutes randomized. The focal volume is 15 by 1 millimeter, which was chosen to be on the order of the nerve size in humans. And then we have a 7.8 megahertz imaging transducer that sits right in the center of the FUS transducer, so that we can use B-mode image to first identify the median nerve and then place it within the focal volume, and then apply our displacement imaging technique to measure the displacement, validate our targeting, and measure displacement traces after median nerve stimulation. And we can take traces from on-target and off-target just to show how spatially specific our technique is. So in the study, we employed 13 healthy human subjects, 5 females to 8 males, and the range is 20 to 40. And so what we saw was that 7 of these 13 subjects had decrease in pain ratings during FUS compared to sham pulses. Now, if we look at all the subjects within their within subject analysis, 3 of those 7 subjects had significant differences to FUS versus sham, according to a Wilcoxon ranked one-tailed t-test. Now, since we have the displacement imaging technique, we can also measure displacement for each rating. So we can take a look at all the ratings, with the max rating being 3.4 change. And we can plot them on a 2D density distribution with over displacement. And then we can run a k-means clustering to show that there are 3 clusters that can accurately describe this data set. And so if we pool all of our subjects together, their change in ratings from their sham to FUS pulses into these 3 different clusters, we see that there's an ideal range between 28 to 60 microns that you have a maximum of change in pain ratings, according to this one-way ANOVA multiple comparisons. So to conclude, FUS decreased pain ratings by up to 3.4 units. The range in nerve displacements for pain suppression was found to be 28 to 60 microns, and our future work includes implementing multi-pulse FUS for greater therapeutic efficacy, because here we're using single pulses. So the idea is maybe if we use a multi-pulse sequence, we can increase the amount of pain suppression that we see, establish feasibility in a neuropathic pain subject population. Well, we also want to look at long-term pain reduction effects. And lastly, for safety and mechanism studies in humans, we're currently implementing a cavitation and temperature monitoring, in addition to the displacement imaging technique that we have. So we can take a look at all the things that are happening during each individual sonication. So with that, I'd like to acknowledge all the people and the funding sources that help make this body of work possible. Thank you.